So what we're going to do now is move on to a couple of cases. And I think it'll be interesting, particularly as we have a nice wide range of speakers from across across the globe, really. What the differences in management options and strategies would be across our different experts. So the first case I'll present is a 31-year-old female who has only a past medical history of some mild asthma and nothing else. Previous normal vaginal delivery 5 years prior, who presents with bothersome stress incontinence and has tried pelvic floor exercises, she says, in the past. So I'd first, with that background, I'd first like to come to Dr. Sinha, just in terms of what are the thoughts going through your mind in terms of management strategies. Would there be any further investigations that you would want on this lady? And what other things are going through your mind?
I think assuming that we have excluded other things which on her evaluation, what we do next is completely determined by the patient's degree of bother. So is she really bothered by the incontinence? Some patients just want a reassurance that it's not a health problem. So I think I would tell her the entire range of what is on offer for her. And if she's really bothered by her incontinence, despite the pelvic floor muscle training and her conservative management, then I might think about things which are more invasive. But clearly, you need to look at her bladder diary. You need to check, that she's voiding well, she's got good void efficiency and so on.
Yes. And, in this case, she is particularly bothered by her incontinence, and she's not tried formal pelvic floor physiotherapy as such. She's had some, leaflets and things about pelvic floor exexercises, but not seen an actual.
One additional issue here that she's just 31. And yes. She's had one child yet. So I would also be interested in understanding what's her, long-term plan regarding further children. And this is a very young age. Any intervention surgical at this age is not going to last a lifetime.
Absolutely. So yeah, that's a very important point. So coming to Dr. Lapitan, what would your considerations be in the Philippines? Again, like Dr. Sinha pointed out, she's only 31. What are the options that you would be talking her through? Considering that we've ruled out any other major issues, there's no other neurology or prolapse or any other red flag symptoms that we can make out.
Well, I think what an important thing that you mentioned is if she has been doing pelvic floor muscle exercises based on just reading leaflets and basically self-teaching her, a self-taught thing. The first thing that I need to check is if she's actually doing it correctly. Because from my experience, people think, some females think that they're squeezing their pelvic floor muscle, then actually it's the opposite. They're actually bearing down during that supposed pelvic floor contraction. So I need to make sure that she's doing it correctly, and if she's not, of course, you have to teach her properly. And then basically that's the first thing, because particularly in the Philippines, we really stay away from invasive because that means more expensive tests. So we will really maximize making sure that all the conservative approaches are offered to her and done correctly. Then second, of course, is to make sure that the diagnosis is correct. So we have to go through all the simple and non-invasive diagnostic assessments, and then offer more complex, like for example, a urodynamics test or a cystoscopy if history and physical examination will point to diagnosis that will be answered by urodynamics or a cystoscopy.
Sure. And in terms of pelvic floor therapy in the Philippines, is that something that you would refer to a specialist physiotherapist, or is that something that you would advise on, yourself?
We don't have a physiotherapist that specializes in pelvic floor, so that will be me teaching the females. Yeah.
Excellent. Okay, thanks very much, Dr. Raghavan. What about you in your practice in terms of pelvic floor therapy? Is that something that you would refer to a physiotherapist, or is that something that you would advise on? Sorry, you're on mute, Dr.
I'm mute. Yeah. during assessment itself, that is the best time I can find out whether the woman has really understood about pelvic floor muscle contraction. So for the benefit of the trainees and the residents, a hand on the lower abdomen and also frequently palpating the thigh and the glutes. Keep 2 fingers in the vagina. Ask the woman to contract the pelvic floor. Make sure she is not doing the wrong muscle, as if contracting the abdominal muscle or trying to squeeze the glutes or the adductors. If that is the case, she's not exercising the right muscle, and teach where is the pelvic floor. That is the best time you can make that opportunity and teach them that is the exact pelvic floor contraction looking for. As Dr. Lapitan rightly prompted, many of the women think bearing down is pelvic floor contraction, which you'll have to unlearn it in the first place and teach them it the right way. And we should not forget the other risk factors in such a young woman, such as obesity and smoking, and as well as other chronic risk factors like constipation and asthma or chronic obstructive pulmonary disease. So whichever measure we resort to, even if it is invasive intervention, this will be amounting to a failure if we have not corrected the primary or the persistent risk factors. And reduction in weight itself, even 5% weight loss, goes to nearly 50% improvement in stress urinary incontinence. So we'll have to concentrate on these things. And then I do have a pelvic floor physiotherapist who specializes in it and who does a 6 to 8 week physiotherapy program with them, with or without biofeedback, depending upon the merit of the case. And I do see 60 to 70% improvement in these patients, provided we have addressed the primary and persistent risk factors simultaneously.
Yeah, excellent. Yeah, some very important points there. Coming back to Dr. Sinha, so now moving on from physiotherapy, when it comes to urodynamics for this case, is that something that you would routinely consider, or only if there were specific factors?
Right. So now we are assuming that we are looking at invasive interventions because otherwise the urodynamics would not be appropriate. So if we are looking at invasive interventions by the guideline, if she's got no urgency, no voiding difficulty, no major prolapse and so on, she actually fits into the uncomplicated patient. And so as per the guideline, she would not require a urodynamics. Would I do it? The answer is yes. In our department, we do a urodynamics for all our patients before surgery. This is regardless of whether they have an uncomplicated presentation or not. I have asked a lot of my colleagues in a similar position, and over a cup of coffee, most of them will tell you that they do it. But I would love to hear what Chris or Stephen or Mary would say about their patients.
Yeah, absolutely. What's your sort of rationale or reasoning behind doing it for most of your patients? Is it just that it provides you that extra bit of information?
Yes, so one is that we do offer transobturator procedures also. And I think if you're going to stratify your patients, it's important to understand what kind of urodynamic findings are there, because we do tailor the choice of the procedure. And to some extent, it's a soft science. I also think we tailor the technique that we do in the individual patient to the kind of urodynamic findings. It's not a hard science there, but there's a soft science there. So I would ordinarily do it. There's a kind of schizophrenia in the urological community. If you ask them, would you choose a separate procedure or do something different for a patient with ISD, they'll say yes. And then if you ask them, how do you make a diagnosis of ISD? We don't do the urodynamics at all for the uncomplicated. So really, there's a conflict within the way we evaluate and treat our patients.
So do you do the urodynamics yourself, or do you have a urodynamic technician?
So I have a urodynamics technician and a continence nurse, because we do a lot of neurourology also. So we have almost between 7 to 10 urodynamics every day. We have a dedicated unit.
Great. Okay. So yeah, coming to Mr. Harding, what are your thoughts on that, Mr. Harding?
Yeah, I agree with everything that Sanjay has said there. I think a couple of things I would pick out just to distill what people have said already. The first one is this patient's age. What are her plans for future? Family, are there going to be further vaginal deliveries? I think the one thing I would add is that her initial evaluation, I would always do a post-void scan to make sure that she's fully empty. But I would urodynamics. The reason I do urodynamics is because I think you in most patients we'll get a mixture of intrinsic sphincter deficiency and urethral hypermobility. I always worry a little bit about colposuspension in the context of predominant intrinsic sphincter deficiency, and that's the reason I do urodynamics. So if she was approaching invasive options, I would go through the what we've got in the UK is a NICE patient decision aid, and that will go through all her options, but I would certainly caution someone with predominant intrinsic sphincter deficiency about colposuspension, because I think that probably would treat the hypermobile urethra better.
Great, yeah, thanks. I think we've got a visual on Professor Jeffrey.
Yes, so I managed to connect to my phone, so yeah, you can see my face now. Short answer, I wouldn't do urodynamics. I think certainly in our environment, we don't have as much access as in India and as in the UK. And in this patient, I would take a much more pragmatic approach. She doesn't have any symptoms of urgency or urgency incontinence. Sounds like avoiding is good. I definitely agree with Chris because to assess her post-residual volume, to check on anything like that. We don't do any transobturator slings here, not in my practice. So my surgical procedure of choice in this patient would if we were going to go for a sling, it would be a retropubic approach, which would certainly treat the ISD in this patient. But as I say, urodynamics is quite expensive in South Africa, and we don't have access to it. And I think that wouldn't really, in my opinion, often change my practice. So, yeah, I think we'll get onto the surgical management in a minute, Arjun, but yeah,
Yeah, I think we'll move on to that actually. So now, if suppose, I know that I threw a bit of a spanner in the works saying that she's 31 and we don't know what she's going to do in terms of her future, deliveries and things like that. But suppose she is 46 rather than 31. She's completed a family and she is looking for invasive management options. Staying with you, Professor Jeffrey, what would be your, first line, second line option for her?
Yeah, I mean, I'm seeing a lot of patients in their mid-40s presenting with exactly the same picture, and I'll walk them through the different scenarios. We have access to physiotherapy, but again, it's difficult and compliance isn't good. Patients don't want to spend their money on 8 sessions of physiotherapy when we know that if she's got demonstrable stress incontinence, it's bothersome, she wants something done. I'm a little bit quicker than many people to go into a surgical intervention, and then I'll walk them through the different options available to us. And we do have obviously all the non-mesh options. You can do laparoscopic birch, I can do bulking, I can do a fascial sling, but in the end of the day, I certainly still balance towards the retropubic TVT in these patients. I've in my hands, I've had very good success with it. It's well reimbursed by our funders in South Africa, and it's often a day procedure, and I've had very good results. So I am still very comfortable offering that to patients. Bulking is an option. We still do it under anesthetic. So that's one of the issues. And so if the patient is taking time off to have an anesthetic, I still sort of move towards the retropubic TVT. We've also got access to some laser treatment in South Africa, but I don't think it works very well. But I reserve the fascial slings and the laparoscopic birch for the complicated patients still in my practice. And I think we're lucky we don't have all that political and media pressure against the synthetic slings.
Yeah, so that's what I was doing. Yeah, whether patients are still largely receptive towards mesh and slings in South Africa.
A lot of them know about it. Before I have any discussion, I'll ask them if they Google anything, or if they've been watching Sky News or any of the UK media channels. And I will often Google it with the patient if they haven't, just to show them what they might find. But patients in South Africa have been shown to be quite receptive to what we do, and I think there's also some research to show that they're a little bit more trusting of the medical fraternity in South Africa than in Europe and in UK. So the culture is still a little bit more sort of deferring to what your doctor will tell you. So that does certainly count in our favor in South Africa. So we comfortably, and so bottom line is we comfortably performed TVTs on most of our patients still. But I would always do retropubic in this patient.
Okay. Mr. Harding, options that you would go for?
Well, obviously I'm restricted in the UK with regards to the use of mesh. And obviously, although I took the stance in the debate against mesh, I'm well aware of the amount of research that's gone into those surgeries. So really in the UK, you would be outlining supervised pelvic floor therapy. You would be talking about bulking agents, which we could do under local anesthetic, autologous fascial sling, which still requires at least an overnight hospital stay. I think if we were to refine the technique even more and try and get this done as a day case, then perhaps the popularity of autologous fascial sling would go up. And I'd also offer them a laparoscopic colpose suspension as well. But the use of the decision aid that NICE have produced is really useful because it's an excellent summation of the existing literature. And different women have different goals. And I think that's what you've got to take into account. There is no right and wrong answer here, but there will be a right answer for a particular patient. And, you know, I get women still 2 years down the line following the mesh ban in the UK asking me when we're going to be able to do TVTs again, because that's what they want.
Yeah, I agree with Professor Harding that the toolkit is a very good aid for us to help patients make a decision. I use it from the RCOG toolkit, which is the same. It's really good.
Yeah. Dr. Lapitan, what about in the Philippines? Same options, or do you have anything? Do you veer towards any particular one?
Well, the tapes are not banned, but they're not available. One, and then laparoscopy is available, but very expensive. So it usually boils down to two things, really: whether the patient will want to go through surgery or not, whether they can afford surgery or not. And if they will go through surgery, we're really limited to just a colpus suspension or an autologous fascial sling. So those are the two options. But generally, particularly in the hospital where I'm working, they will really go through the end doing non-surgical options. So, yeah.
Yeah. Thanks everyone. I think, we've highlighted some important points there. And I think for trainees coming through, I think that probably the key thing is that all these options are on the table. It's very much a case of making sure that your patients are aware of all the options, guiding them through the data and the evidence on them, and then helping them to make a decision. At the end of the day, it is their decision. And the more involved they feel in their care, I think the better the outcome will be for both for us and our patients. So I think that's probably the key message. We'll do one more case very quickly if we can. I know we're almost at the end of our session here. So case number 2, I'd like to get Mr. Ali in for this one. So this is a 40-year-old male with a history of a T5 spinal cord injury 2 years previously, who manages his bladder by self-catheterization and still has reasonable ability to do that, but complains of urinary leakage. So just in terms of initial evaluation things, how would you propose going about that?
Okay, yeah, so that's something that is quite a sort of common situation that you know. So I think in the first is you'd want to see. I mean, he's obviously been self-catheterizing for a while. You probably have, certainly in our practice, you probably have some baseline urodynamics that we'd have a bit of an idea of what his bladder function has been like whenever that was done. There may be an argument for repeating that, if we suspect that there has been some significant change. Generally speaking, patients like this, we would also be getting upper tract imaging on quite regularly. There's kind of two elements when you're thinking about this sort of patient. There's the element of the inconvenience to the patient of the urinary leakage. And clearly, from a patient perspective, that's the most important thing, okay? And one has to appreciate that. However, there's something else going on, and that is what is the safety of the bladder? If a patient is leaking, is that because the pressures in the bladder are increasing? And if you go in gung-ho and try and sort that out, and you don't sort out the underlying problem, you may actually make it socially more convenient for them, but actually you're actually making, in the long term, you may be damaging them, particularly if they're getting higher pressures in the bladder. So I think the first thing to establish is, are things like the upper tracts, are they okay? Is there an issue in terms of bladder pressures? However, in most patients, it is what it appears to be. It is leakage. It's usually due to neurogenic diffuser overactivity. And as long as there's not an upper tract issue developing because of raised pressures, then I think what you're going to be looking at is probably in a sort of a stepwise fashion, looking at firstly making sure that they're catheterizing appropriately and on a timely basis, that they are emptying their bladder properly. Then looking at sort of pharmacological management, that would probably be the anticholinergics in the first instance. So either the short-acting ones like oxybutynin or the longer-acting ones, tolterodine or solifenacin. And then you may also add on the beta-3 agonists as well, although they've not been specifically looked at in as much depth for neurological patients because it's somewhat newer. And then beyond that, you're talking about things like intraversatile Botox injections and then other surgical options. Thankfully, nowadays, actually, most patients can be the sort of almost the upper point is intraversatile Botox.
Yeah. Thanks for that. That's a comprehensive overview from someone who works in a tertiary spinal injuries unit. I would expect no less, and I think Dr. Sinha would concur with that evaluation completely. But I'm interested to get Dr. Lapitan's view of spinal injuries patients in a unit like yours. Would they get a similar kind of robust follow-up and investigation, or does it have to be a little bit more ad hoc?
Well, unfortunately, they usually come to us always nearly with high creatinine levels, dilated upper tracts already. It's because they're not really bothered sometimes with the leakage. They will just bear the leakage. They're used to wearing diapers, if ever. So unfortunately, some of our patients come to us in that state already. But when we do catch them, I guess we really need to do a repeat urodynamics. We will have to find ways to get that done to sort out the reason why he's still leaking. And as mentioned, we go through all these stepwise therapeutic interventions to manage that leakage. But one thing really that is also, a characteristic of the Filipino patient is that they're very tolerant. So they will suffer or accept a little bit of leakage if that will mean, not going through surgery, but still protecting their kidneys. They'll suffer through a little bit of leakage. So, yeah.
Right, yeah. Dr. Sinha, any comments?
I just wanted to add one small point, and that is all these patients must have a CIC diary record. You can't manage the patient without a CIC diary. So at every step, the diary needs to be seen. When they're incontinent, you add an antimuscarinic, see what happens on the diary. You need to correlate at every point.
Great, thanks very much. Right. Once again, I'd just like to thank everybody for their input on this. It's been an excellent session, very comprehensive overview in what has been inevitably a short time period that we've had. These are topics that we could talk about for days if we had the opportunity. But thanks to everyone for joining. I've got a couple of things just before we finish. So we had the MCQs, which we sent out to everybody to answer. I'll just very quickly give you the answers. We don't have time to go into any great detail, but just to go through very quickly the answers. So the first question was about the guarding reflex, and the answer to that is answer C. The guarding reflex refers to gradual increase in striated sphincter activity seen during normal bladder filling and storage. So that's question number one, is answer C. Question number two, a reflex neurogenic bladder as described in the Lapides system is characteristically seen in which of the following? The answer is A. It's a traumatic spinal cord injury between the sacral spinal cord and the brain stem. Question number three, a 62-year-old man has bothersome frequency and urgency with rare leakage. He has no obstructive symptoms and post-void residual is 20. Urinalysis is negative. His only therapy has been 2-week course of oxybutynin, but he's currently on no other medications. The next step is answer A. Behavioral therapy, including dietary modification, fluid management, and bladder training. And that's just in relation to the fact that the question does not mention that any of these things has been tried previously. Normally that would be first line. but that hasn't been mentioned as being tried before. So you would still go back to those before trying anything else. Question 4, for women with stress incontinence, urodynamics has its most useful role in which of the following scenarios? The answer is A, it is in women who are considering surgical correction, who also have urinary urgency, incontinence, or difficulty emptying the bladder. And question 5, the ostium of a urethrodivesticulum, in relation to its location, the answer is E. It is located on the ventrolateral urethra, and it's most commonly at the 4 and 8 o'clock positions. So those were the answers. We had about 25 people attempting those, and we have the top 3 scorers, and also those who scored the quickest, and they are Dr. Anuj Kumar, Dr. M. Anas Abu, and Dr. Faraz Khalil Khana. So well done to the 3 of you for getting all those correct. So just before well done. So just before I finish off, I'd just like to thank Cipla and also the iTrue team behind this, who've done a lot of work in putting this together. So thanks to Anurag and Nitesh and the others